The Diffusion of Innovation Theory by Sarah Kloster. As seen by the infographic, the diffusion of innovation theory was developed by E. Rogers, and it was originally focused on adopters of new technology, but the theory also provides a framework for describing how, why, and at what rate new technologies spread through social systems. You can see that there are 4 phases of diffusion, and the adopters are put into 5 different categories, and there are also many characteristics, but mainly the theory focuses on 5 main ones. So the development, within his framework, the 5 characteristics of innovation are most influential. Those include the relative advantage, which the innovation is seen as better than the idea it replaces, the compatibility, which it's consistent with values and needs of the adopters, the complexity, which is how difficult the innovation is to use, triability, can the innovation be tested or experimented with before it's truly committed to by an adopter, and observability, does it provide concrete results when it's actually implemented? The application in public health intervention planning is more applied to step 5 of intervention mapping. So it helps the planner think carefully, consider who the adopters are, what is influencing those adopters, is there any outside stimuli or social factors, what is the building process, and is the process easy to understand, and is it better to understand the process? The primary constructs, so there are 5 different categories that adopters are put into. And so these are innovators, which are the venturesome or those really early people who adopt these, the early adopters, who are the opinion leaders, the early majority, who are the deliberators, the late majority, who are still skeptical and have quite a few questions, and then the laggards, who are more traditional and don't really feel like adopting it unless it's absolutely necessary. The secondary constructs, so there's dissemination, which is the planned systemic efforts to make a program more available, the adoption, which is the uptake and commitment to initiate the program, the implementation, which is the active efforts to implement a program in a setting, and the maintenance of sustainability, which is the ongoing use of the program after the initial resources are used and incorporation into routines. So these are the 4 different phases that the adopters go through. So there was a case study for glucose screening program. So the Quality Improvement Initiative to implement a best practice fasting glucose screening was developed using this type of theory. So ongoing reinforcement by the medical director was used in the form of newsletters, individual screenings emailed out to the primary physicians for these patients, and the averages shown at staff meetings to see how those patients were improving. There were 4 different clinics that were used in this case study. They were all under the same health system, but there was over 7,000 patients that were included. So as you can see from the figure 1, so average screenings increased 67% during the first intervention period. And then during the second intervention period, it increased to 90%. There were still some issues with 2 of the clinics where they weren't really increasing. So they were trying different things specifically towards those clinics to see if they could improve the intervention period numbers. This was able to provide successful results for quality improvement. And with the things that they did for these patients, with those emails sent out to the physicians, the medical director actually making rounds, going to these specific clinics and seeing how patients were interacting was really a way for them to improve the quality. They did say that more study is needed to evaluate individual patient characteristics that may affect screening rates. So that's including the self-efficacy of the patients, their willingness to improve their glucose scores, if they truly feel that this is necessary for them to be working on. A second case study was research to practice gap in autism intervention. So as a result, autism programming in the community has not been found to improve adaptive, social, or cognitive functioning. So this theory was used to further understand and implement a better autism intervention. So this was more along the lines of seeing how the public school administrators could work with those students who were diagnosed with autism or on the autism spectrum, and how they could help them in everyday school life. So during dissemination, the administrators were made aware of programs and encouraged to adopt them. During the adoption phase, administrators formed their attitudes towards the intervention and if they were willing to commit to initiate the program. The implementation, they were beginning to use these different innovations that they found throughout the program. And then during the maintenance or sustainability, the innovation moves from implementation to institutionalization. So they made a commitment to continue or discontinue the use of the program. So this was based on what they decided as a cohort on what they felt worked best for those students. So the key stakeholders, what they decided was the families, teachers, clinicians, and administrators, all those who work closely with those students, must be involved in developing a research agenda to foster the large-scale use of effective treatments. And then researchers also improved organizational capacity to support interventions by working with key stakeholders to improve their willingness and ability to adopt, implement, and maintain the intervention. So this again was mostly for those school administrators working with a program for those students that had the autism. So the pros and cons of using this theory, the pros are there are many stages for an individual to fall under. So whether it be, if they're an early adopter or a laggard, it really depends on what type of intervention is being used. There are different channels, so they could be either media or interpersonal through that type of communication, and whether or not you're an early adopter or a innovator, you might use more media, whereas a laggard might use more interpersonal communication because they prefer that face-to-face. There's also the rate of diffusion increases based on participation, persuasive communication, and social support and modeling. So the cons is this tends to work better with adoption behaviors rather than quitting or prevention, such as smoking cessation. This doesn't take into account social support or other resources. So again, there could be other outside variables that are affecting somebody's choice to adopt a new behavior, or if they have the social support to adopt that new behavior. It can really depend on the person and their external situations as well. So there also is no guidance on how to address the factors based on the implementation framework. So the critical evaluation of this theory. So I found that there's lacks trust from those who have used the theory. So in the case studies, it did seem that the researchers didn't put a lot of faith in using this theory as a way to implement their behavior changes. It also lacks effective ways of implementation through the multiple constructs as pros, which leaves, because there's so much room for variability. It could be difficult to determine where you stand, whether you're a innovator and a early majority or a laggard, or even depending on what phase of the theory you are in. So for the intervention mapping, it focuses on diffusion of a health program, which it doesn't focus on the full theory, just the diffusion of that program. And then it's active process or passive failure to familiarize self with the innovation to decide. So the individual really has to either choose to actively process this innovation program, or if a passive failure would be they just don't listen to it or they don't recognize it. And those are my references.